Welcome, everyone, and thank you for joining us today to discuss the results of the Institute for Medicaid Innovation's 2022 Medicaid Managed Care Organization Survey. My name is Dr. Jennifer Moore, and I'm the founding executive director of the Institute for Medicaid Innovation, a national 501c3 nonprofit, nonpartisan research and policy organization focused on providing innovative solutions that address important clinical research and policy issues in Medicaid through multi-stakeholder engagement, research, data analysis, education, and quality improvement initiatives. Our mission is to improve the lives of Medicaid enrollees through the development, implementation, and dissemination of innovative, evidence-based practices and models of care that promote quality, value, equity, and the engagement of patients, families, and communities. As we say at IMI, it's not the statistics that make Medicaid real. It's when you love one of those numbers. As a former Medicaid enrollee myself, I understand how important this program is to individuals, families, and communities. Everyone enrolled in Medicaid is much more than just a number. That's why we're here today, to go beyond the numbers and tie the results back in meaning and understanding the meaning of our survey findings and how they affect the lives of Medicaid enrollees, caregivers, families, and communities. There are fascinating findings and insights to share, and I look forward to hearing the opinions of our esteemed reactant panel members. But first, we'd like to thank the Medicaid health plans who carved out a substantial amount of time every year to respond to over 895 questions in the survey. Good news though, next year's survey will be much shorter. We would also like to thank the Robert Wood Johnson Foundation for its generous, ongoing support of this critical work. We are honored to have Andrea Ducas here with us today to provide opening remarks. Andrea is a senior program officer at RWJF, working to transform our healthcare system and push for policy changes that have a meaningful impact on people's lives. Andrea, the floor is yours.
Thank you so much, Jennifer, and thank you also to the fantastic panelists that you all are going to hear from today. It is such a thrill to be here and to have a couple of minutes to chat with you before we dive into some pretty exciting survey results. At RWJ, we are working toward a future where everybody can live their healthiest life possible. And specifically when it comes to our interactions with the healthcare system, we want our healthcare system to be fair and just, to treat all people with dignity and respect, and to rectify past harms and prevent future ones. It's been a real interesting time during a little over a decade at the foundation, where our focus has shifted pretty dramatically from an initial focus on quality improvement and disease reduction to really thinking about how to support culture change, transformative culture change in healthcare. And we have a lot of great partners who are helping us achieve that vision and who are really doing that work. One of which is the Institute for Medicaid Innovation. We are thrilled to partner with them and to be producing or to helping them produce this really important report. As Jennifer shared, Medicaid is a vitally important program. Its success is key to ensuring that populations all over the country have access to dignified and respectful care, and care that will actually meet their needs. So it's important for us to have a sense of how that care is being delivered and trends in the sector, so that we know that we are doing our best work at RWJ to help shape the future of that program in our vision of achieving a transformed healthcare system. So I don't want to take up too much more time, so I'll just thank you again, Jennifer, and your whole team. And also I'll echo the thanks to the Medicaid health plans for the effort that they not only put into completing the survey, but also into shaping it. I hope that you all ask really great questions as the panel goes on, and you know where to find me and this team if you have follow-up questions and want to probe even further. So thank you so much, and back to you.
Thank you, Andrea. We certainly appreciate the commitment and support of the Robert Wood Johnson Foundation. Now, before turning things over to our panelists, let's review a few key facts and insights regarding this year's survey. As I mentioned, with over 895 questions that the health plans respond to, there's a lot of information. But let's just focus on a few key facts. The survey captures information from across 11 domains, ranging from value-based payment and social determinants of health to behavior and child and adolescent health. Respondents include Medicaid health plans of varied sizes, representing both single and multi-state health plans. There are multiple trends, insights, and data points to be analyzed, but when we looked at the data this year, we really coalesced around a few key highlights that I want to highlight for you now. So first, we must acknowledge the fact that by necessity, COVID-19 fueled the largest scale change in health policy and clinical care since the Affordable Care Act. The public health emergency increased the number of Medicaid enrollees to a historic high at about 90 million people, driving the need for increased access to care, especially among populations disproportionately affected by the pandemic. As we witnessed together, Medicaid health plans rose to the challenge, meeting the needs of more enrollees than ever before. The program excelled at its primary purpose, the purpose to serve as a healthcare safety net that protects access to care for those who need it most. Medicaid health plans capitalized on policy and regulatory changes made during the public health emergency to ensure barriers to care were diminished, including guaranteeing continuous enrollment for Medicaid enrollees, ensuring that their access to healthcare through telehealth services. Care delivery approaches like telehealth that began growing at the start of the pandemic continue to develop, with 90% of Medicaid health plans reporting that enacting service and benefit flexibilities in response to the public health emergency strengthened their telehealth capabilities. In fact, 71% of health plans reported that these flexibilities increased patient access and supported continuity of care and services. The pandemic created opportunities to implement value-based purchasing and alternative payment models, and bolstered health plans' commitment to equity, with more than 81% of Medicaid health plans now stating that they have or are planning to pursue NCQA health equity accreditation. If we can only share one recommendation from what we have learned during the pandemic experience, it's that Medicaid health plans, policymakers, and advocates have a really important opportunity to identify which policy and regulatory modifications have been made, their greatest impact on improving care delivery and service supports for Medicaid enrollees, and then consider how these changes can be sustained beyond the public health emergency. Clearly, some pandemic era flexibilities should be made permanent. IMI's survey of Medicaid health plans can inform crucial policy discussions about this. To be clear, many emerging trends, challenges, and opportunities surfaced over the past year. Some are familiar, issues that healthcare has been dealing with for decades that were further amplified. Others are new and growing opportunities to ensure access to more holistic, integrated care. The first of these challenges is related to data collection and sharing and the technical infrastructure required to do so effectively. Survey respondents focused on three key areas of data and technology challenges. First, unclear regulatory guidance. Second, out-of-date technology. And third, a lack of interoperability or the ability of different systems to work together to share information. Let's talk about the data a little bit more in detail. 86% of Medicaid health plans reported that better data sharing would help them address social determinants of health. 71% of Medicaid health plans cited lack of access to information from previous providers as a barrier to coordination of care. And more than half of health plans identified access to data between care management and behavioral health teams as a barrier to care integration. And finally, even telehealth delivery could be improved, as 2/3 of Medicaid health plans said provider IT systems were a barrier to effectively delivering telehealth services. Of course, none of these challenges are new, but they did cause severe problems during the pandemic by limiting effective contact tracing and population-based data analysis. There is broad agreement that when providers, community-based organizations, and social service organizations securely share information, outcomes improve and costs decrease. Our ability to share data has been limited for years, but the pandemic has given us a new understanding of why it's so important that we address this at the federal, state, and local levels. We also have an opportunity and obligation to improve access to mental and behavioral health services. I am sure you're all aware of the skyrocketing rates of demand for these services, especially among Medicaid populations. Between the survey data, Medicaid's historical challenges ensuring access to mental and behavioral health care, and a shortage of providers, particularly those who accept Medicaid, becomes clear that we are teetering on the edge of a crisis that could quickly spiral out of control if not addressed. The survey sheds light on where Medicaid health plans and their partners need to focus improvements. For instance, 94% of Medicaid health plans identified limits on sharing information about treatment of substance use disorder as a barrier to integrating care. And 88% of health plans cited an inability to deliver integrated behavioral and physical health care at the same point of care as a key barrier. Communication was also a significant concern. 41% of Medicaid health plans cited lack of communication as a key barrier to integrating behavioral and mental health services with physical health services. We would all agree that we must focus on improving access to mental and behavioral health care, and the moment to do that is right now. The stigma surrounding mental and behavioral health has seemingly decreased as society has more open conversations about the realities that we all sometimes need and benefit from mental health support. The public dialogue around these issues has become more informed, nuanced, and empathetic than it has ever been, even just a few years ago. Medicaid health plans have an ability to meet this moment by committing to ensure access to comprehensive care that takes into account Medicaid enrollees' physical, mental, and emotional health. The pandemic has underscored that Medicaid works. And I've got to say that again. The pandemic has underscored that Medicaid works. The social safety net did not break. It stretched. And in doing so, it protected many of the people who need care the most through policy and regulatory changes and health plan flexibilities. It's been a challenging time, but it's also been a challenge that, for the most part, Medicaid health plans have risen to meet. In fact, Medicaid health plans have made great strides in supporting coverage, increasing access, and advancing population health over the past few years. We cannot afford to lose this progress. The survey highlights that there is an urgent need for policymakers to ensure that the most successful of the pandemic's policy flexibilities continue to benefit Medicaid enrollees in the long term. The findings that I've highlighted are just a very small snapshot of what you can find in the survey results. There are many more fascinating insights and trends within the survey data, and we encourage you to read the fact sheets and review the data points. We sincerely hope that the survey will serve as a jumping off point for rich, informed discussions like we're about to have today with our panel, and among other health plans, policymakers, community groups, clinicians, and the general public about how we can strengthen and improve Medicaid program, enhance the lives of Medicaid enrollees, and spur healthcare innovation more broadly. With that, now I'd like to introduce the members of our esteemed panel who will further discuss what the results of this surveys mean. Karen Dale is the Market President for Amerihealth Caritas DC and Chief Diversity, Equity, Inclusion Officer for all of Amerihealth Caritas. She's responsible for leading key initiatives to strategically position the MCO as a market leader, offering innovative solutions for the critical challenges faced by its members. Karen also serves on the IMI governing board as our treasurer. Next is Gail Graham. She's the director of Mount Lebanon Baptist Church HIV/AIDS Ministry Outreach Services and a commissioner on the Baltimore City HIV Planning Group. She's an advocate for community-informed Medicaid improvements that reflect the needs of enrollees and is a member of IMI's National Advisory Board. And finally, Dianne Hasselman is the Interim Executive Director at the National Association of Medicaid Directors. She manages a broad spectrum of activities, including planning the organization's public policy and advocacy agenda, overseeing grant-funded programs, ensuring members get their needs met, and developing new initiatives. I'm going to pose a few initial questions to the panel to start off today's conversation, but please contribute yours via the Zoom Q&A function. We want you to also participate in the conversation. So with that, let's get started. My first question to the panel is intended to reflect on the entirety of the survey findings. As you reviewed the results in advance of today's event, I'm curious, did anything surprise you about the findings? Was there anything that you didn't expect to see? Dianne, I'm going to start with you.
Sure. Hi, everyone. And Jennifer, again, congratulations on this achievement, another year, and it is indeed a celebration. So congratulations to you and your whole team. And thanks for including NAMD in this conversation. So, in looking at the results, and there are a lot of results, there is a lot of information in this. It is packed full. I think what actually struck me more than anything was there is so much alignment across what health plans are facing in terms of successes, challenges, what the things that they're dealing with. There's so much alignment with what state Medicaid programs are also dealing with. Challenges with the collection of REL data that continues to be challenged. Challenges with the direct care workforce in behavioral health or MLTSS, communication between multiple providers for kids with special health care needs, integrating physical and behavioral health at the point of care. I mean, there are so many areas where, states and plans are just in lockstep, which should not be surprising. So, I think those would just be a few of the things. Nothing really jumped out at me and surprised me. I guess I was excited to see the reduction of several barriers. It seems like over the 5 years, you can see the trend line starting to go down, which was just super positive. And then again, the investment made during COVID and what a powerful and productive investment that is for not only these last couple of years, but particularly moving forward.
Which underscores the importance of how we sustain these flexibilities that we experienced during the pandemic so that we can continue to see these improvements in the trend lines in this survey, as you mentioned, aligned with both the state Medicaid agency and the Medicaid health plans who are in lockstep. They're partners working together to deliver the Medicaid program. I'm going to now ask Gail to share with us any surprises from the survey findings as you reviewed the results.
Apologies. Surprises for me was for the behavioral and mental health, the communication barriers that were there. I was surprised by that. I was also surprised about the number of contracted midwives and the percentage of the doulas that were being, paid for, especially with the high mortality rate for, Black females giving birth and everything. So when I saw that, and for especially with COVID, many people started going towards the doulas and going towards the midwives, and then finding out that their insurance companies are not really covering it. So I was really surprised about that. And I also was surprised about the social determinant of health, the programs like for the HIV, only 29% are covered for HIV clients with Medicaid. And, this is something before COVID came, we've had HIV for years and we're still not being funded for services that's needed. So.
Thank you for that, Gail, and really appreciate the on the ground in the community perspective that you provide and share that within the context of this survey. So thank you for that. We're going to dig a little bit more in your perspective in a little bit. Before we do that, Karen, want to give you an opportunity to share any surprises that you identified when reviewing the findings in advance of today.
I have definitely a couple. The first one is workforce. I was celebrating the fact that 100% of the Medicaid plans said that they were using community health workers. Awesome, awesome, awesome. And that certainly reflects growth over the years. With our knowledge of the demand that we have and the shrinking workforce, I was surprised, similar to Gail, to see the decrease, not as high a use of doulas, not as high a use of peer support workers or perinatal community health workers. The narrative and the research around the inequities that Black women or Black birthing people face, it's unequivocal at this point. And so the fact that we don't see corresponding workforce changes is an opportunity. I was also concerned that only 33% of Medicaid plans said that they were tracking outcomes for effectiveness that were non-HEDIS, such as emergency room utilization. It is certainly known to be a leading indicator about whether the healthcare system, delivery system is truly accessible, right?
Mm-hmm.
And it tells us something often about whether our provider network in terms of primary care is adequate and culturally responsive, right? And so if we are not looking at that and then disaggregating that data on REL, in an REL way or geographic way, we're losing an opportunity to lean in and create better delivery systems. On the payment strategies used, we know that behavioral health is a place where we need to invest more, especially if we want to have primary care and behavioral health more co-located or linked integrally. And so we should be thinking about all those payment mechanisms that could be leveraged. And that seemed like we're not doing as much there. So again, another opportunity. And then finally, on the impact of COVID section about the value-based payment, only 50%, it said, were reconsidering their long-term organizational strategy around value-based payment. And that's a missed opportunity. Big lessons learned about how to help providers remain stable and vibrant. And we need to be doing a lot of rethinking at this point.
Thank you, Karen, for that. And thank you for your service on the CMS HEAT Health Equity Action Task Force and really bringing together the equity lens to value-based purchasing, alternative payment models. And thank you for bringing that lens to the survey results and your reflection of the key findings. I want to now dig a little bit deeper. Each of you brings a unique perspective. Karen, you have the health plan perspective, Dianne, state Medicaid agencies, and Gail, such a strong force in the community in Baltimore. Would love to hear from you what you think the main findings and takeaways from where you sit from your perspective. So Karen, again, your health plan, Dianne, state Medicaid agency, and Gail, as a patient advocate and community leader. What does that look like from your perspective? And Karen, let's start with you this time. What are those key takeaways that you will walk away from the survey and take back to your health plan?
Sure. Again, a lot around the maternity component. I'm just saying, wow, this is a missed opportunity. And when we take care of birthing people, we take care of two generations, right? And we know the cost, both the human cost and the healthcare cost is much higher. So a couple of things there. Said that only 13% were focused on patient-centered contraceptive counseling. And that's fairly easy to do, right? We can be doing much more in terms of at a well woman visit, right? And during the pregnancy, having those conversations, making things like long-acting reversible contraceptives very easy to obtain. And having that conversation, understanding that woman's choice, right? So she can make an educated decision. That's something that should be happening as a routine part of a woman's healthcare. 48% of all Medicaid health plans said they were offering specific programs to address the needs of people with diverse sexual orientation and gender identity. We know the toll that discrimination plays for these populations and that they are often going to suffer higher rates of anxiety, depression, potentially suicidal, right? And during the pandemic, due to isolation, many were much more harmed and set back in terms of flourishing. And so ensuring that we're addressing those needs is super important. And we should be collecting data, educating our teams, and educating providers. Again, back to maternal health, only 52% are providing childbirth education classes. Missed opportunity. to collaborate with community-based organizations who have the trust of the community and do amazing work, amazing work. And so those are some areas that I think we could really improve if we were utilizing consistently an equity lens. And equity requires us to not do for people, but to first engage with them in terms of meaningful conversation, honoring their perspective, and having that inform how we approach the interventions.
Very person-centered, right? And reflecting on the need to listen to the community and hear what their needs are and what their wants are, and being responsive to that. Karen, you mentioned a couple of times, and others, REL, and I'm going to throw in SOGI. Do you want to share with the audience, in case they're not familiar, what REL and SOGI data stands for?
Sure. So REL is race, ethnicity, and language data. And when we begin to look at our data in that way, it's not the only lens, right? But as we grow in our maturity to collect more broad information on who we serve, all those dimensions should really be assessed. People with diverse abilities, you know, I mean, just all of it, right? And I know sometimes people talk about it being challenging when looking at race, ethnicity, and language data, because people have intersecting identities. So you could have someone that is Latinx and a member of the sexual orientation and gender identity community, so they're non-binary, you know. However, like, we should be doing that work because it's all about who we serve and improving opportunities for them to achieve their full health potential. And so getting in that habit of, one, partnering with providers and or community-based organizations to get the data, having the discipline to utilize that information to help us recognize where there are disparities, and not just looking at data, always going the extra step to have a qualitative conversation with not only who is served, but the community and the context of the community where they are, so that we are best informed, right? We're taking as many slices looking at it and being as informed as possible to have the appropriate context, allows us to have a much more specific way of addressing interventions and evaluating whether they've been successful.
Thank you, Karen. In some way, that's a call to action for everybody, not just for health plans, but each stakeholder in Medicaid, because we all play a really critical role. I want to move to Dianne and ask her the same question. You know, what are the key takeaways that you feel that you'll take back, that you feel state Medicaid agencies will take back from the survey findings?
So I think it's the thing that struck me was kind of also the continuing push and pull, kind of the ongoing tension between all of the different partners involved in the Medicaid program. So between, you know, the states and the health plans and the providers, the health plans and the CBOs, you know, the physical health of the side, the behavioral health side. And this is just, Medicaid is such a kind of a team sport, for lack of a better analogy. It involves everyone, and there's always such a push and pull and a tension of, you know, who should lean in on this, who should take the lead on this, who should be, and it's everybody playing their part and their role. So I just think there were lots of threads of that kind of throughout the findings. I think the other thing that the Medicaid directors would be interested in is looking a little more deeply into the kind of the scale or the reach or the depth of some of the findings. So for example, around the telehealth barriers, understanding a little bit more that, you know, all of the plans mentioned that members experience barriers, and just maybe going more deeply into that. Or for example, the VBP arrangements, you know, is that, you know, how pervasive is that in the primary care book of business, for example, or the reach of benefits that, you know, the doulas, the midwives, et cetera, for childbearing people. So I guess, Jennifer, just collect even more data than you already are. There's not enough. No,
add beyond the 895 questions.
Exactly. Please add a few hundred more. No, but I guess those were a couple of things that kind of struck me from the Medicaid director perspective.
It almost lends itself to a qualitative component to this project and something to consider to bring that voice more prominently behind the data. Again, returning back to the individual, the family, the caregiver, the community, but also the health plans and the state Medicaid agencies and building out that context and richness behind the data. Gail, community perspective, what are the key takeaways that you will take away back to your community from the survey findings?
Actually, some of the key things that really hit me was the fact that the percentage of Medicaid health plans providing maternity-focused training for providers to partners to improve birth equity was less than 50% in a lot of areas, with the exception of the large health plans. In this day and age, it should be higher than that. And yes, there's a part that says no, but considering or working on. Well, it's good that you're doing that, but it needs to be action behind that. So I was that made an impact on me to say something about that, as well as for the diverse sexual orientation and gender identity programs. Same thing there. And then it was just even less to an extent. But the medium health plan stood up to the gate to do something about this. So that's a plus, and I really like that. But in all honesty, I just see a need for the community to be more active or more part in every part of this. You know, I'm hearing everything about the providers, the technical part and everything. But if we have meetings to include the community in those same meetings, where the community can say, you know, this is something that's affecting, this is not working here. And it's not just one person, you go into them at the end or something like that. But if they're included in every aspect, I think it would make a big difference. And the plans will be more geared holistically towards everybody. And it would also improve the communication between the doctors. And because when there's no communication between the doctors, especially the mental health, not putting their information into the electronic thing, that's hard, because as you're doing your other doctor visits, something mentally could be exacerbating your health. And if the other doctors don't know, what's going on with your mental health, then, that could also cause problems for your health. So
Yeah.
I just think it's more of a need to include the community in all aspects of even the survey.
That's such a great point, Gail, and really aligns with IMI's primary strategic priority that's embedded in our mission, vision, values, and that is community and equity. At the end of the day, if you're not engaging community and centering equity, you are not making changes that are meaningful, sustainable, impactful, and value-based. So thank you, Gail, for really driving that home. Dianne, you look like you want to add on to that. Is there something you want to share?
Yeah, I just, listening to Gail and just thinking about an additional area, and I know the Medicaid directors are thinking about this very deeply, and we have a session at our upcoming fall meeting on this, is how to authentically engage the perspectives of people with lived experience. How do you, Jennifer, exactly what you're talking about, how do you place them at the center, and what are the formal ways that Medicaid agencies and also health plans are inviting people, bringing them to the table, incorporating their feedback? What are they weighing in on? That whole piece of work, I think that would be fascinating to look at, and even more questions, Jennifer, to add and expand the survey. But anyway, I just think that would be great. And I know the Medicaid directors and NAMD, we're looking at that as well, and trying to share best practices and who's doing a really good job and what is the secret sauce of that. So yeah, so I would support everything Gail has said.
And what a great project idea for IMI to consider. It's definitely an area that's ripe for discovery and sharing of information. There's a huge need for it right now, and would love to chat with Medicaid health plans and their Medicaid enrollees and what that meaningful partnership has looked like, how they have connected with community and use that information to inform the programs that they lead and deliver, and return back for feedback ongoing. So thank you for that idea. I know Karen has been doing that in DC at her health plan, but I was gonna send it over to her, but I know that we've getting a ton of questions in the chat, and I want to make sure that there's an opportunity to connect with our participants and ask their questions to the panelists for responses. So as we're pulling them together, I would like to ask a quick question. You know, an individual wrote in the chat, I don't work for a Medicaid health plan or a state Medicaid agency. What can I do with the data to help increase and improve care for enrollees? Boy, that first question is really centered on what we've been talking about. Gail, I'm going to hand it to you first.
Okay, ask that one more time. I'm sorry.
Yep, that's okay. It's a big question. So the individual wrote in the chat, I don't work for a Medicaid health plan or state Medicaid agency. What can I do with the data to help increase and improve care for enrollees?
Well, you can, you're educating yourself, and then you can educate your community about what's going on with the health plans. And then as you see the disparities within the health plans, then you can become an advocate and speak up about what needs to be done. So even though you're not, you know, head person in these organizations, your voice matters, because you can choose what health plans you want. So you can, you know, stop one health plan and go to another. And when they see that you're not satisfied, they're going to wonder, well, what do we need to do to satisfy this participant or, you know, this client? So again, that's what I would do. I would use the data that we have here, and where there's disparities and things that really interest me or bother me, I would, you know, let my community know and find out how they feel about different things, and then go back and become an advocate for that to make the changes.
Great. Thank you, Gail, for that. That's well stated. And thank you for sharing that wisdom. I'm sure that it's helpful for a lot of us who are listening to this event. The next question, going back to maternal health, that is the second most popular topic for today's discussion. And this one is from Kevin, who would like to know what would move the needle to have more health plans, especially large health plans, contract with midwives and doulas. We know that licensure requirements in a state affects this to a degree. Are health plans communicating about updates needed at a state level to increase this type of workforce? Which evidence suggests will improve maternal health outcomes? Anyone want to take that one first?
I can jump
Karen.
in.
Yeah.
You know, sometimes I ask people a question. I say, what must you believe to take action? What must you believe to take action? And so sometimes the inequities, the disparities that cause the outcomes that we see, there's not enough investment in learning, understanding the research, and believing. If you believe, and we're not talking recent, even though it's just become more recent, that it's part of the national dialogue, the research is decades in the making. And so it is a decision, right? What we think about, what we value, what we believe drives our actions. And so I think we've got to start there. The business case exists. You think about the cost for someone that has a baby that ends up in the neonatal intensive care unit. You think about the cost when a woman has to have a C-section and or has an infection after. And that's just the healthcare cost. There is a human cost to the people we serve, the people who care about them, and their communities. And so it comes back to, we have to decide that we believe and that we view the service we are paid to provide as one that requires us not to check boxes, but rather to expand our lens so that every human being that we serve, every one of them, has that opportunity to have a healthier, more positive health outcome. And that is achievable. And when we do that, guess what? The return on investment is there because the total cost of care is reduced.
Thank you, Karen, for that. Dianne, it looks like you want to jump in.
Yeah, I guess I would just, from a very practical and pragmatic, I have heard from a couple of states there are workforce challenges around being able to find doulas and to find midwives. And I don't know if this is just kind of part of the challenge to the delivery system created by COVID and the fears or concerns about in-person care or something larger. I don't know, but I don't know, Jennifer, if you've heard something like that. Karen, if you've run into that or have any insight, because I thought that was fascinating. Here we found something that is incredibly powerful and effective, and we're struggling to fill the provider spaces.
Sure. So midwives, it's longer formal training for certain. However, we have to decide what we're going to invest in, right? So if we believe that this is really important, partnering with the universities, making sure we work with the hospitals on practicums. I mean, it's not like they're not solutions. We have not invested the time and energy to create the partnerships to help move the outcomes. It doesn't happen overnight, but we have to get started. Doulas can get their appropriate training and certification in a smaller amount of time. Interstate compacts can be entered into so that coverage, right? If they're certified, I live in a metropolitan area, we are going to be using for our doulas the certification that it's, we've identified 3 entities that certify. And they don't have to be in DC based. They just, when they get certified, have to have a DC Medicaid number. These are things that can be solved. So and that's my inclination always anyway. I've never met a problem I didn't see some type of solution for, right? So we've got to lean into this. And what I see is that, well, if you can come up with that as an issue, then the conversation stops. There's so much more that we can do in partnership, right? For those people who have the ability when we work together to help move us forward. And we should be doing that.
Thanks, Karen and Dianne. And for those who are maybe less familiar with midwives and doulas, midwives provide clinical care and support, and doulas provide birth support in a different way, not clinically based. And so that is the big distinction between the extended training and education that midwives receive, but together it's a very powerful combination of community-based services and supports that have been shown to be high value and evidence-based. And to Diane's question about some of the challenges, oftentimes we hear about challenges around reimbursement rates and that the reimbursement rates are not sustainable. Midwives, birth centers have to worry about how many Medicaid enrollees that they will bring into the practice because the reimbursement rate is lower, and it's hard to maintain their practice. Just a plug for this, because this is just a perfect place. IMI is leading a national midwifery learning series and a learning collaborative helping to overcome some of these challenges. We have 5 state-based teams in the state of Michigan, state of Washington, state of California, Kentucky, and Arizona, who are all really digging in to figure out these solutions. Each team has a state Medicaid agency representative, Medicaid health plan, midwives, community-based organizations, tackling these issues. And we're looking forward to releasing what we're learning, what we're finding, so that it can be replicated across the US. We also are going to be launching a doula learning series, another great plug here. So for anyone who's trying to figure out, like, how do we make doulas work in our state? How do we make perinatal community health workers work in our state? we've got the series for you, and I'm sure my colleagues would be happy to put the link in the chat so that everybody has access to that. So let's pivot now. Although, maternal health is one of my favorite topics, but my second favorite is around maternal health. And our next question that has come in is from Jane. And she says, the challenges with sharing mental health and substance use disorder data between physical and behavioral health providers is notably a huge barrier. Other than needing regulatory changes, what other actions might ease this barrier? This is such a critical component to truly achieving whole care, whole person care. So with that, I want to open it up. What do we believe we can change, building off of Karen's mantra for us all to take forward? What can we change to support this?
I'll jump in. I think people are starting in the wrong place on this in terms of the barrier. The barrier says you can't share the information, or the perceived barrier is you can't share the information without the person's permission. So if someone is sitting in your office and you have the opportunity to have a conversation, get the consent. We find that the consent conversation doesn't even come up. And I'm going, well, wait a minute, right? And that's a great way. It's not just about getting the consent. The conversation is about the person's whole health and helping to do some increase in some situations with health literacy to say how things are connected, right? Your emotional well-being is connected to your physical health, right? So that person that is early diagnosed with a chronic condition is very likely to experience anxiety, which untreated leads to depression. And so now you've got a chronic disease and a major depression diagnosis, right? And so that's a great opportunity to have a conversation and say, something may not come up, but it could. And let's have a conversation about me having, as your primary care provider, the ability to share information as needed and appropriate with the extended care team so that we can work best together to meet your needs holistically, because we don't want to be separating your head and your heart from the rest of your body and what else is going on. And we miss over and over again the opportunity to have that conversation, albeit sometimes providers say, like, so you all just keep piling on all the things you want us to do, and you haven't reduced the administrative burden to free us up to do this piece. So it is a yes, and yes, we want you to have these conversations. And as Medicaid managed care organizations, we have to develop the ways in which we reduce administrative burden so people are focused on the human beings sitting in their offices.
Thank you for that, Karen. And we're going to have to move on now. We actually received more questions than we could possibly get to. Thank you to each of you for submitting questions, comments. I promise you we are going to read them afterwards. I know that several were providing some ideas, so thank you for that. Before we close though, I do want to pose one question to our panelists, and this is a question that we always ask our panelists before we close out. If you had a magic crystal ball to predict the future, what do you think will be elevated in the report next year? So last year, we asked our speakers, our panelists, that same question, and they highlighted: 1, workforce shortages, both providers and among state administrators. 2, data collection and shared standards to evaluate equity work. 3, more integration of community-based organizations. And 4, the expanded roles of community health workers. It's as if they knew exactly what 2022 was going to look like. So now we want to think about 2023, and love to hear from the panel. What issues will you predict will take center stage in the coming year? And what trends, issues, and developments do you think we'll be talking about next year in this release event? So Dianne, I'm going to start with you.
Yeah, I mean, for the Medicaid directors, it is 110, 150% focused on the PHE unwinding. And so that's what they are looking at, and they are crouched at the starting line, ready for the gun to go off and to start that process as are their teams. So I think that's going to be top of mind from the Medicaid director perspective, is just looking at coverage rates, looking at churn, looking at the equity perspective of who is on the program, who is no longer eligible for the program. So I think that is going to dominate. I think workforce, again, is going to dominate. It is so critical for both states and plans. So I think that's going to be another. And I think, again, those are so massive. And probably the behavioral health crisis is also going to be top of mind.
Great. Thank you, Dianne. Gail, what do you think? Hot topics.
I still think the behavioral health and also the maternity issues, but also what we're missing too is the underrepresented population who are not going into the hospital except for emergency room visits. I think that still is not really being addressed. Regardless of COVID or anything else that's going on, we still have a population that's not comfortable with coming into the healthcare field. And so they're not getting well checkup visits. They're not being taken care of the way they supposed to. This is one of the reasons why COVID spread as fast as it spread, as well as other diseases out there. So I think that that's something that will still be an issue in 2023.
Thank you, Gail, for that. Karen?
I won't repeat the ones I've already heard, so I'll add to the list. We're going to be talking about the PHE flexibilities, what stayed, what didn't, and what was the fallout from that. It is not an easy thing to figure out how to shift power balance. Medicaid managed care organizations are not the be all and end all of how health happens. And so we'll have to figure that out. How do we shift our role and leverage community-based organizations and truly share power so that they are reimbursed and recognized for the value they bring to improving health outcomes? That's going to be a journey that we have to take together. The piece about, alternative payment models so that we address the disproportionate adverse or people that are socially complex and medically complex that some providers have. We have to acknowledge that those providers face a more difficult journey in terms of having the time, the staff, right? And the ways that they need to connect people to the services they need. And so they will need that support and assistance in order to achieve that. And these are sticky problems. They're not ones that we'll quickly resolve. However, so I think we'll still be talking about them, and hopefully the results will show that we've made meaningful steps on that journey.
Great. Thank you to each of you. Thank you for joining us to discuss the annual Medicaid MCO survey on a Friday afternoon. I really appreciate Gail, Dianne, Karen, for your time today, for sharing your knowledge, expertise, perspective in relation to the survey. Truly, your commitment to improving the lives of Medicaid enrollees is critical, no matter what angle you approach it from. So thank you to each of you as our panelists for your insights, and thank you for the work that you do each and every day. For the rest of us, a recording of this webinar and a feedback survey is being placed in the chat box and will be sent to you early next week. Please share your thoughts with us so that we can continue to meet the needs of the Medicaid community. Finally, you can access the survey findings as part of our new fact sheet series using the link in the chat box or at our website. We'll include all of this information with a recording of today's event in the post-session email. I want to thank especially once again to the Robert Wood Johnson Foundation for their ongoing support of this important work. And I would be remiss not to acknowledge the amazing, incredible IMI survey project team, including Dr. Emily Heberlein, Lydia Tonkino, Sarah Hurlbert, Becky Landucci, and Sydney Berry for all of their work on this project, along with Medicaid Message Partners for their support of this event. With that, I'd like to thank each and every one of you and have a wonderful weekend.